All right, now let's dive into chapter 12. This is our Antimicrobials chapter. And this is where I think the course really starts to get fun. You're going to take all that information you learned in the first unit of this class, the information about the cell wall, cell membrane, transcription and translation, bacterial metabolism, the viral replication cycle. And you're going to take that information and we're going to apply it to antimicrobial therapy. So you're really going to see the point of what you learned in that first unit come to fruition in this chapter. And I think that makes it exciting and interesting. So let's go ahead and get started. So just a brief history of antimicrobial therapy. Most of you probably know that penicillin was discovered accidentally. It was discovered by Alexander Fleming, a Scottish bacteriologist, back in 1928. That's less than 100 years ago. So antibiotics are a relatively recent development. And how he figured this out is he noticed that his petri dish of Staphylococcus had a contaminant in it that was mold, and the area around the mold was inhibiting or not growing any Staphylococcus bacteria. And you can see that in his photograph here. You have the petri dish, you have colonies of staph here growing. Here's his contaminant, the mold colony. And this area of clearing around the mold, he noticed, is where bacteria were prevented from growing. Now, he was probably not the first person in history to put this together. We actually know that ancient Egyptians used to apply moldy bread to infected wounds. So this knowledge has been around for a while, but it's only in the last 100 years that we've really put it to practical application in our everyday lives. So what Fleming did is he took the mold, he isolated it, and he identified it as being in the genus Penicillium, and then he extracted a substance from the mold, which he named penicillin. And it was the penicillin that was inhibiting the bacterial growth. Now, this was mostly just a curiosity of the lab for about 10 years. Microbiologists used this information when it came to growing their microorganisms, but it didn't really find practical application in medicine until about 1939. So, that's right around the beginning of World War II that we saw antibiotics really hit the market. And it changed the lives of not just the soldiers during World War II, who we saw death from infections drop dramatically, but it changed the lives of everyday people as well. So think back on a time that you've taken antibiotics in your life, either for a sinus infection or a sore tooth, something like that. Over 100 years ago, that would have been potentially a death sentence. The use of antibiotics has made these infections go from being life-threatening to essentially just being an inconvenience in our daily lives. Before we had antibiotics, simple infections, skin infections like cellulitis and erysipelas were often fatal. Sepsis, which is a blood infection, it's when the bacteria get in into your bloodstream and start multiplying. That was incredibly common, and it had a very high mortality rate. STIs were incurable, and some of them were deadly. Paper cuts could kill. Of course, you get a skin infection and it spreads to your bloodstream. You get sepsis, and again, sepsis had a mortality rate well over 80%. And then another thing we saw was mothers and babies routinely dying shortly after childbirth from infectious causes. So antibiotics have revolutionized our lives. This has given us a tool against one of our greatest enemies, which is the pathogenic microorganism, okay? Now, having said that, we are seeing a global trend that's very concerning, that is antibiotic resistance. And we're seeing a rise in antibiotic resistance among microorganisms, especially multi-drug resistance, okay? So when these microorganisms develop resistance to more than one drug, it makes it even more challenging to treat them. And so we're seeing the resurgence of diseases that we thought were things of the past. Things like tuberculosis are making a comeback due to drug resistance. And this is due to a couple things. Number one, it's due to overprescription by providers. Providers have been too willing to prescribe strong antibiotics for minor infections. You should always use the most specific, the most targeted antibiotic that you can to treat an infection. Number two, patients themselves don't finish the course of antibiotics, so they don't kill off all of the pathogens that are there. And so these factors have led to the development of drug resistance among several microorganisms. And we're going to learn a little bit in this chapter about drug resistance, about the mechanisms, the strategies that these microorganisms use to avoid the effectiveness of a drug. But we're also going to learn about the genetic underpinnings, the mechanisms, genetic mechanisms of how these microorganisms actually acquire their drug resistance. So we'll learn about that, as well as learning about antimicrobial therapy. Okay, so what is the goal of antimicrobial therapy? Well, the goal is to administer the drug to an infected person that's going to destroy the infective agent without actually harming the infected person's cells. This perfect drug does not exist. Every drug that we have has some side effects that are the result of harming the host cells, okay? Antimicrobial drugs are going to be produced either naturally by microorganisms or synthetically in the lab. You can also produce them semi-synthetically. That's where you take a natural antibiotic produced by a microorganism and you alter it in the lab. So really, antimicrobial drugs can either be natural, semi-synthetic, or synthetic. And like I mentioned, the perfect drug does not exist, but what we do is we try to choose the best drug, the one with the most acceptable side effects, or potential side effects, I should say. So what does the ideal antimicrobial drug look like? Well, we said this drug doesn't exist, but if it did, this is what we would be looking for. We would be looking for a drug that is selectively toxic, so it's only going to harm the microbe. It's going to be non-toxic to the host cells. We would choose a drug that's microbicidal, so it actually outright kills the microorganisms rather than just being microbistatic, that is making them stop growing. We would choose a drug that can remain potent long enough to act, and it's not going to be broken down by the body or excreted prematurely. We're going to choose a drug that could not be subjected to antimicrobial resistance. Again, remember, this ideal drug does not exist, and every drug is going to be subject to the development of antimicrobial resistance. But ideally, you would have a drug that could avoid that. Ideally, you would have a drug that assists the activities of the patient's own immune defenses. Ideally, your drug would remain active once it reaches body tissues, and even when it gets diluted in those body tissues and fluids. You would have a drug that's readily delivered to the site of infection. So if you have a kidney infection, this drug would target, would be delivered to the kidneys, okay, and avoid the other parts of the body. Your drug would be reasonably priced, and the drug would not disrupt the host's health by either causing allergies, predisposing the host to other infections, or causing adverse side effects, okay? So again, this perfect drug does not exist, but this is what we're looking for, or we're trying to get as close to this as possible when we choose an antimicrobial for our patients. So where do antibiotics come from? Well, we said one thing is that they are produced naturally, all right? So they're actually common metabolic products of different bacteria and fungi. For example, bacteria in the genera Streptomyces and Bacillus, and molds in the genera Penicillium and Cephalosporium. These are common microorganisms that we use to extract antibiotics from. Why do these microorganisms make the antibiotics in the first place? Well, the goal is the microorganism wants to inhibit competing microorganisms. So if they can exude a substance that destroys other microorganisms around them, they have first dibs on all the food, all the space, okay? All the nutrients. They have first dibs on the environment. So that's why they produce these antibiotics, is to basically take out the competition. This table just shows the genus of some different microorganisms and what drugs we get from them. For example, penicillium, obviously we get the penicillins from them. Cephalosporium produces the cephalosporins. We get aztreonam from Chromobacterium. And then look at all of these drugs that we extract from Streptomyces, the Streptomyces genus. So these are all produced by different species in these genera. And like I said, they can be left unaltered so that they're like natural antibiotics, or we can take them in the lab and we can alter them, and then they will be semi-synthetic antibiotics. All right, this is a list of a bunch of different terms that you need to be aware of. And I've bolded the terms that are likely to appear on a test here. So I would definitely recommend that you be intimately familiar with these bolded terms. So chemotherapeutic drug is going to be any chemical used in the treatment, relief, or prophylaxis of a disease. That's a very general term. When we say chemotherapeutic drug, I mean, this could be a medication for blood pressure. It could be a medication for cancer. It could be a medication for an infectious disease. All of those medications are chemotherapeutic drugs. Now, specifically, antimicrobials are going to be any antimicrobial drug, regardless of its origin. So this is going to be anything that acts against a microorganism in an infectious disease. Next, you have antibiotics. This is more specific. This is a substance produced by the natural metabolic processes of some microorganisms. Okay, so that's the definition of antibiotics, is that it comes from a microorganism and it can inhibit or destroy other microorganisms. Now, generally speaking, when we say antibiotics, we usually mean antibacterials. All right, so I try to keep my terminology of antibiotics limited to antibacterial drugs. If it's another antimicrobial, like an antifungal, I'll say antifungal, I'll say antiviral. But when I say antibiotics, I'm talking about antibacterials. We've got semi-synthetic drugs. I mentioned these are going to be drugs that are chemically modified in the laboratory after being isolated from natural sources. Okay, so we can have semi-synthetic antibiotics where we take like the natural antibiotic and then we alter it in the lab, and then we've got a new antimicrobial drug. You can also have synthetic drugs. These are antimicrobial compounds that are synthesized entirely in the lab using a series of chemical reactions. I want you to be familiar with the difference between narrow spectrum and broad spectrum antimicrobials. Narrow spectrum antimicrobials are going to be effective against a very limited array of microbes. So you may have a drug that only targets gram-positive bacteria. That would be narrow spectrum. Broad spectrum is going to be an antimicrobial that's effective against a wide variety of microbes. So you could have a drug, for example, effective against gram-positive and gram-negative bacteria. That would be an example of a broad spectrum antimicrobial. Prophylaxis, you need to know, is the prevention of something. So when we say we're taking a drug prophylactically, what we're doing is we're using that drug to prevent a potential infection in a person at risk. So let's say you're working in the ER and a patient comes in and the patient is found to have bacterial meningitis. Well, if you were in the same room as that patient at any time, even though you're not exhibiting any symptoms of bacterial meningitis, what they're going to do is they're going to prescribe you a prophylactic antibiotic. And then you're going to take that antibiotic ahead of time before you get sick to prevent bacterial meningitis or the potential of bacterial meningitis affecting you. Okay, and then down here we have antimicrobial chemotherapy. This is kind of a catch-all term for chemotherapeutic drugs used to treat infectious disease. So remember, chemotherapeutic drug is any drug that treats any disease. Antimicrobial chemotherapy is any drug that treats an infectious disease. I want you to be aware of combined therapy or combination therapy. This is where a patient will take multiple drugs at the same time to fight an infection. Okay, so these drugs might act slightly differently, and when they're used together, they are more powerful than when they're used by themselves. That is called synergy or synergistic effect, and I want you to be aware of this term. This is the enhanced effectiveness that occurs when certain drugs are used in combination. One example we'll talk about is the brand name Bactrim. The generic is sulfamethoxazole and trimethoprim. It's two different drugs combined together, and when they are combined, they both act on the folic acid pathway, and their actions become synergistic. So they're more effective at killing the microorganisms when taken together than when taken by themselves. Okay, here's that concept of selective toxicity again. So a drug that is selectively toxic is going to kill the microbial cells without also damaging the host cells, okay? And this is going to be very important because you don't want to take medicine that's going to also hurt yourself, right? The problem is that as the characteristics of the microorganism become more similar to our characteristics, selective toxicity becomes more difficult to achieve. So you see more side effects. For example, bacteria are easier in some ways to target because they have different structures than eukaryotic cells. So if we were fighting a eukaryotic microorganism like fungus, that can be more difficult to eradicate a fungal infection than it is to eradicate a bacterial infection. Again, because the effectiveness of antifungals is going to be limited by its toxicity to our host tissues, okay? So the more similar a microorganism is to us, the more difficult it is to find a medication that's not going to cause really bad side effects in us. Okay, so there are 5 major drug targets we will talk about in this class. And when I say drug targets, what I'm talking about is the part of the microorganism that the antimicrobial is acting on in order to destroy that microorganism. For example, some drugs inhibit cell wall synthesis. So if you inhibit the ability of the microorganism to build its cell wall, you're going to weaken that cell, and that cell can rupture and die. And that's one way you can kill a microorganism. Some drugs interfere with the integrity of the microorganism's cell membrane. Again, if you interfere with the integrity of that cell membrane, that microorganism's cell can weaken, and it can rupture, and the microorganism dies. You can also have drugs that interfere with the functions of DNA and RNA. If you interfere with the microorganism's DNA molecule, you can introduce mutations into the microorganism the next time it divides. And so the next time it divides, it tries to replicate its DNA, and because you've damaged that DNA molecule, mistakes are going to be made. When mistakes are made, the wrong proteins are going to get made. There's going to be problems with the genetic output of this DNA. And so you're going to have dysfunctional proteins made. Dysfunctional proteins are going to interfere with the integrity of the cell's structure and ultimately will lead to cell death. Similar concept happening with drugs that inhibit protein synthesis. So if you stop the ability of the microorganism to make its proteins, it's not going to be able to, say, make enzymes for its metabolic pathways. It's not going to be able to make parts of its cell wall. It's not going to be able to anchor down its cell membrane. things like this, okay? And all of these factors lead to disruption of the integrity of the cell and ultimately the death of the cell. And then finally, you can block key metabolic pathways directly, usually by blocking an enzyme in that pathway. And again, if you break down the microorganism's metabolic pathways, it can't metabolize its nutrients, it can't make energy, and it will eventually die. All right, I've included this slide for your own review as you're going through here and learning about the different drugs and the cellular targets of those drugs. You can refer to this chart and kind of see easily and visually represented interference with the cell wall, interference with the cell membrane. And you can see here the list of drugs that interfere with the cell wall, the list of drugs that interfere with the cell membrane, that interfere with DNA and RNA, etc. So use this slide. If you find it useful, use it for your own review. We'll go into detail on most of these drugs here in just a second. Okay, so I mentioned the spectrum already. So the spectrum is going to be the range of activity of your given drug. You can have narrow spectrum drugs that are going to have a small range of microbes that they act on. And you can have broad spectrum drugs. These guys are going to act on a greater range of microbes. Now, how is spectrum determined? Well, you'll find that the narrow spectrum drugs are going to target a specific cell component that's only found in this small range of microbes. Whereas your broad spectrum drugs are going to target cell components that are found in most microbes. Okay, first let's talk about drugs that are going to target the cell wall. Remember that bacterial cells, their cell walls contain peptidoglycan. Okay, and what peptidoglycan is it's this compound that's composed of a repeating framework of long sugar chains, these guys right here, cross-linked by these short protein fragments, these green lines right here. And it creates kind of a lattice. And what the cell wall is it's multiple layers of this lattice, of this framework, layer upon layer upon layer. And it provides structural support and rigidity to the cell. The beta-lactam antibiotics, I want you to be familiar with these. These are the penicillins, the cephalosporins, and the carbapenems. These are going to inhibit the enzymes that help that framework cross-link. So there's when you've got these sugar chains, you want to cross-link them with these peptide fragments, right? These short protein fragments, and you need an enzyme to do that. Now the beta-lactams inhibit that enzyme. So what happens is you get these glycan chains that are not cross-linked. So you've just got like a bunch of sugar wires, essentially, without any cross-linking. So it makes the cell wall very weak, very liable to fracture. Okay, so the beta-lactam antibiotics act on the cell wall because they inhibit enzymes that help that peptidoglycan cross-link together. So that's going to weaken the cell wall, and eventually there's going to be a change in osmotic pressure, and it's going to lead to influx of fluid into the cell, and the cell is going to rupture. This is going to work on growing cells that are actively building their cell wall. So obviously if the cell already has its cell wall built and it's not synthesizing any more of these enzymes to build its cell wall, these drugs aren't going to work. It's most active on the growing cells. Now, some penicillins are narrow spectrum and some penicillins are broad spectrum. The difference here is the narrow spectrum penicillins can't penetrate the outer membrane of gram-negative bacteria, so they're not going to be effective against gram-negatives. The drug cannot get inside of the cell to inhibit those enzymes that are building the cell wall. Broad spectrum penicillins, on the other hand, and cephalosporins and carbapenems do cross the outer membrane of gram-negative bacteria. So they can get inside the cell, They can inhibit those enzymes that are building these peptidoglycan layers. So they can affect gram-positive and gram-negative organisms. All right, drugs that disrupt the cell membrane. So a microorganism that has a damaged membrane is going to die either from interference in metabolism. Remember that our prokaryotic friends metabolize nutrients on their cell membrane because they lack mitochondria. Or the damaged membrane can lead to cell rupture. Okay, so they have a specificity for a particular microbial group based on differences in the types of lipids that are in the cell membranes, okay? So depending on the drug, it's going to act on a different type of lipid. For example, the polymyxins interact with phospholipids, especially in gram-negative bacteria, and cause the cell to leak, and ultimately the cell ruptures and dies. Amphotericin B and nystatin are antifungals, and these guys form complexes with sterols in the fungal membranes. I will talk to you about what that means later on. Ultimately, you need to know that these guys cause leakage in the cell membrane, and that can cause the cell to rupture. Here's an example. You can see our polymyxin B. The drug is inserting itself into the cell membrane of the target microorganism. And when it does that, it breaks up the cell membrane. It interferes with the integrity of the cell membrane. And so fluid and particles are free to flow in and out, and eventually this cell will rupture. Okay, drugs that affect nucleic acid synthesis. So this is going to interfere with DNA and or RNA. What these drugs can do is they can block the production of nucleotides, right? These are the building blocks of DNA and RNA. They can inhibit replication of DNA, or they can stop transcription of DNA into RNA. For example, rifampin inhibits bacterial RNA polymerase. This is an enzyme that helps the bacteria transcribe information from DNA into RNA. And remember that RNA goes on to be made into a protein. So if you stop transcription, what you're ultimately stopping is protein synthesis down the line, and then the cell can't make the proteins it needs to live, and it dies. Quinolones are another example. These guys inhibit DNA helicases, and what these helicases do is they help unwind the DNA molecule and keep it stable during that unwinding. And so when you interfere with that unwinding, you're inhibiting proper replication. And it can introduce breaks into the DNA molecule, and there can be mistakes made during replication as well, which can lead to mutations in proteins, and you're going to have abnormal proteins, and again, abnormal proteins are going to ultimately lead to cell death. Okay, some antiviral drugs are analogs of purines and pyrimidines. So let's take a step back. What does that mean? Well, purines and pyrimidines are the nitrogenous bases that make up nucleotides, and nucleotides make up RNA and DNA. They're analogs, meaning they look like purines and pyrimidines. So the enzymes that build DNA and RNA take these analogs thinking that there are purines and pyrimidines and insert them into the growing nucleic acid molecule. The problem is that these lookalikes don't act like purines and pyrimidines. You can't add more nucleotides to the molecule once you've put these analogs in. There's nothing to build onto these analogs, okay? So the chain that you're building of the nucleic acid stops. It's cut short. Okay, so what happens is these analogs are incorporated into the growing viral DNA or RNA molecules, rendering them defective. And so new virus particles are going to be either defective or completely non-functional and unable to infect more cells. And so that's how these analog antivirals work. All right, then you can have drugs that directly block protein synthesis. So recall that ribosomes are going to be the site of protein synthesis in both eukaryotes and prokaryotes. We both have ribosomes. And the ribosome is kind of like a table on which the protein gets made. It's actually an enzyme that helps catalyze all the steps to build the protein, to oversimplify it. And so you can have drugs that interfere with the action of this enzyme, and so that the mRNA molecule can't get read and made into a protein molecule. Now, recall that eukaryotes and prokaryotes have different size and structure in their ribosomes. For example, the eukaryotic ribosome is 80S, and the prokaryotic ribosome is 70S. And what that means in a very practical sense is that if we have drugs that selectively target the 70S ribosome, there's going to be fewer side effects because they're going to leave our 80S ribosomes alone, so our cells can continue making proteins. Now there is one caveat to that. Remember that mitochondria are unique in that they have their own DNA and they have their own ribosomes as well. And the reason for this, if you think way back, is that a long time ago, one prokaryotic organism, such as a bacterium or an archaean, enveloped another prokaryotic organism, and they learned to live together. And that's called the endosymbiotic theory. And so a long time ago, if you go far back enough, the mitochondria is thought to have evolved from the prokaryote that got engulfed. And it would make sense then that the mitochondria has conserved its own DNA and its own ribosomes throughout the ages. So because of this similarity that the mitochondria have to prokaryotes, they can suffer some damage from these protein blocking drugs. All right, so note that there's going to be several ways that we can block bacterial protein synthesis. For example, the aminoglycosides are going to affect the 30S subunit of the bacterial ribosome, and this is going to cause misreading of the mRNA. Tetracyclines, on the other hand, are going to block the attachment of the tRNA molecule to the ribosome and stop protein synthesis that way. Macrolides are going to inhibit the ability of the ribosome to move that mRNA molecule down and read it. Linazolid is going to prevent the assembly of the ribosome and prevent the ribosome from starting to read the mRNA molecule. Okay, so we'll go through these in detail, and just to give you an idea of the underlying mechanisms behind these different protein blockers. But really, the big picture I want you to remember is that all of these drugs are going to block bacterial protein synthesis, and they're going to do it by inhibiting the bacterial ribosomes. Okay, for example, we've got the aminoglycosides. This would be something like streptomycin or gentamicin, and they're going to attach to the small subunit, the 30S subunit of the bacterial ribosome. And what this is going to do is it's going to cause this mRNA molecule to be read incorrectly, and the incorrect protein is going to be made, or it's going to stop being made altogether. Chloramphenicol is going to block the formation of peptide bonds, so the protein chain cannot grow. Linazolid is going to block the large subunit and the small subunit from coming together and assembling, and this is going to result in lack of initiation. So the protein's not going to get started to made. It's not going to be made at all. Tetracyclines, such as tetracycline and doxycycline, these are going to block tRNA attachment, and so no protein is going to be made. Remember that the tRNA molecules are the guys that are carrying the amino acids, and those amino acids get put together via a peptide bond, and that's what builds the protein molecule. The protein molecule is just a bunch of amino acids connected to one another via peptide bonds. Okay, so then you've got macrolides such as erythromycin, and these are going to prevent the ribosome from being able to translocate the mRNA molecule. So cannot move down the molecule, cannot continue reading it, so elongation is going to be prevented, or the growing of that amino acid chain, that protein is going to be inhibited. All right, and then finally we have drugs that are going to affect metabolic pathways. So here comes that concept of competitive inhibition again. And remember, this is going to involve a drug that looks like the normal substrate for an enzyme. And so it's going to compete for the active site of that enzyme. It's competing against the enzyme's normal substrate. So that's why it's competitive inhibition. The problem with this is when a competitive inhibitor binds to the enzyme, it cannot go on to become the products that enzyme normally makes. So the pathway, that metabolic pathway that relies on that product being made, gets shut down. And this results in cellular metabolism slowing or stopping. The examples we'll talk about are going to be sulfonamides and trimethoprim. Okay, remember that a synergistic effect is going to be the effect of a combination of antibiotics that's greater than the individual effects of the antibiotics by themselves. For example, sulfonamides and trimethoprim. Together, they block different enzymes required for folic acid synthesis. And folic acid is needed to make DNA and RNA. Okay, so here we have the folic acid pathway. It looks really complicated, but I'm just going to walk you through it. This is PABA right here. This is kind of the starting molecule. And this is an enzyme. And via this enzyme, it's going to turn into dihydroapteric acid. And this enzyme here is called DHPS. Sulfonamide inhibits DHPS. So this can't get made. Now, however, you have another step down here. Dihydrofolic acid gets turned into tetrahydrofolic acid. There are other pathways that can feed in here that can feed dihydrofolic acid to this pathway. And you can still come out with folic acid. So what happens is you use trimethoprim and it blocks this step. And together, both of these steps being blocked is going to shut down this pathway better than any one individual step being blocked by itself. Okay, this is showing sulfa drugs as competitive inhibitors, and this is just kind of illustrating in real space what's happening. So here you have PABA. This is the normal substrate of this enzyme here. And then this is a sulfonamide. This is a drug. And you can see it looks similar structurally, and you can see that here. This is a hexagonal shape, so the hexagon kind of fits into the enzyme like so, while the inhibitor, the drug, kind of looks like a hexagon as well. You can tell it's definitely not the same molecule, but it can fit into the enzyme at the active site. And so what's happening here is that the sulfa drug, the inhibitor, is competing with the substrate for this active site. And again, when this inhibitor binds to the enzyme can't make any product from it. So in effect, it shuts down this step of the metabolic pathway. Okay, so this slide and the next slide have the drugs listed for you and what their effects are. I want you to be familiar with the ones in bold. All right, so let's just go through this list together. We've got the penicillins and the cephalosporins. These guys are beta-lactam antibiotics. I want you to know that, and I want you to know that beta-lactams inhibit cell wall synthesis. That's going to damage the cell wall and result in the cell rupturing. Aminoglycosides and macrolides and tetracyclines, I want you to know, these guys inhibit protein synthesis. You don't need to know the exact mechanism, but I do want you to know, big picture, proteins are not going to be made when you give these antibiotics to the bacterial cell. Fluoroquinolones we'll talk about in a little bit. These guys are going to block replication of DNA. Sulfa drugs we've already talked about a couple times. And I want you to know that sulfa drugs, or sulfonamides, are going to inhibit folic acid metabolism. Okay, so those are all antibacterials, right? Antibiotics. For the antifungals, I want you to know amphotericin B, and I want you to be able to recognize the azoles. And I want you to know that these guys are antifungal drugs. You should also know that they cause loss of membrane permeability. And I have an antimicrobial review packet that I'm going to go over with you guys. And I'll explain exactly how these guys do that in more detail. But really what you need to know is that they're antifungal. Amphotericin B in particular is used for systemic fungal infections. All right, the drugs that work against protozoa, I want you to know the quinines and metronidazole. Primarily, I want you guys to be able to recognize that these are antiprotozoals, okay? Don't have to tell me their mechanism. The antihelminthics, you need to be able to recognize the bendazoles, such as albendazole. Don't worry about the mechanism. The only thing that I want you to know the mechanism for is going to be some of these antibiotics here, the ones in bold. Ivermectin, I want you to also be able to recognize that this acts against helminths. Now your viruses, I don't want you to worry about memorizing them, recognizing them, anything like that. If you're asked a question about an antiviral drug, I'm going to give you the mechanism of the drug's action, and I'm going to ask you which step of the viral multiplication cycle does that drug act on. Okay, so you'll need to review the viral multiplication cycles again in order to get these the questions about antiviral drugs correct. Okay, question. Aminoglycosides are antibacterial drugs that target, okay, and if we go back and we look, we remember aminoglycosides are going to be an antibacterial, and they inhibit protein synthesis. So the answer here is C. Okay, factors that we consider when choosing antimicrobials. So some of you are going to go on to become providers yourselves, and you're going to come to a point where you need to prescribe someone an antibiotic. So what are you thinking about when you think about which drug to prescribe? Because there are literally thousands of antibiotics on the market. Well, first and foremost, you're going to want to know exactly what the infection is caused by, and you're going to want to know the structure and nature of the pathogen. What kind of drug does it respond to begin with? Then you want to go a step further and you want to find the drug sensitivities of the pathogen. So you basically take the pathogen, you grow it, and you grow it in the presence of a bunch of different antibiotics, and you figure out which antibiotic is best at killing off that pathogen. And we're going to do that in lab this week, actually. Patient factors you need to take into consideration. First and foremost, allergies. Never prescribe a medication that a patient is outright allergic to. Next, you need to think about the patient's comorbidities. So what other diseases do they have? Do their kidneys work okay? Is the drug excreted through the kidneys? Or is it metabolized by the liver? Does the patient have liver problems that you need to worry about? Also, other medications the patient's taking that can interfere with the efficacy of your antibiotic or even make your antibiotic stronger than you want it to be. You need to think about the side effects of the drug. You need to take these patient factors into consideration and ask yourself, can my patient tolerate the side effects? You need to consider the type of infection that's happening and the tissue that needs to be penetrated by the antibiotic. For example, if the patient has a urinary tract infection, you want that antibiotic to get into the urine. You want it to be excreted so that it gets all flushed through that urinary tract and acts on the bacteria that are there. You need to consider whether you're prescribing empiric or targeted therapy. Empiric therapy is when you don't know exactly what the cause of the infection is, but you're going to treat for the most possible pathogens that you can. And so this usually involves a broad spectrum antibiotic. The reason we use empiric therapy is basically to buy ourselves time until we get the drug sensitivities of the pathogen back. This can be very important in severe infections like meningitis, where you just need to treat as best as you can because every moment is important. Targeted therapy, on the other hand, is going to be a situation where you know what this particular pathogen is sensitive to, so you select the most targeted drug that you can. You're going to consider the route of administration. So if you're treating someone outpatient, you're not going to prescribe them a medicine that must be given IV. Along those same lines, you're going to consider dosing frequency. So if there's a pill that a patient has to take 4 times a day, that's going to be more difficult for them to adhere to than a pill they only have to take 1 time a day. You want to think about the storage requirements of the medication. Some antibiotics require refrigeration, and not everybody has access to a refrigerator. So ask yourself, is this a patient who might not have access to the proper storage methods? And if so, you might consider an alternative medication. Finally, the price of the medicine should be considered. If there is an alternative that does the exact same job and it's cheaper, you should always, for the sake of the patient, prescribe the cheaper medication. For example, the difference between a name brand drug and its generic is negligible. Therefore, prescribing the generic, unless there's a really good reason not to prescribe the generic, prescribing the generic is the better thing to do. All right, moving on, let's talk just briefly about antifungal drugs. So the problem with fungal infections is that fungi are going to be eukaryotic. So they're going to have an ADS ribosome like us. And this is going to make selective toxicity challenging. So the majority of antimicrobials out there are going to be designed to act on bacteria. So we only have a few antifungal choices, a relative few. The main groups of drugs that we'll be talking about are going to be the macrolide polyene antibiotics. This is going to be amphotericin B primarily, griseofulvin, synthetic azoles, flucytosine, and the echinocandins. But what I really want you to focus on is going to be amphotericin B and the azoles. I want you to be able to recognize those. Okay, so the drug groups, we've got the macrolide polyenes. This is going to include amphotericin B and nystatin. Amphotericin B, I want you to know, is used for systemic fungal infections. And these patients with systemic fungal infections tend to be very, very sick. And one of the problems with that is that the nickname of amphotericin B is amphoterrible B because it has some really severe side effects. So if you've got a patient who's being given amphotericin B, chances are they are extremely sick. Griseofulvin, don't worry so much about this. The synthetic azoles, I want you to be able to recognize ketoconazole, clotrimazole, miconazole. These are going to inhibit ergosterol synthesis. I'll show you what that means in just a second. Flucytosine. This is an analog or a look-alike of cytosine, and this is going to interfere with DNA replication and transcription in the fungal organism. It can be used with amphotericin B for systemic mycoses. And again, we're looking for that synergistic effect, right? The echinocandins are going to interfere with cell wall synthesis. And I'll show you what I mean right here. Okay, so this is illustrating the fungal cell wall and the cell membrane. So here is a fungal cell. This red line is going to be the cell wall. The green line is going to be the cell membrane. And here we're zooming in on a portion of it. So this section here is the cell wall. And then this down here is the phospholipid bilayer, the cell membrane itself. The thing to know about the fungal cell membrane is that it has ergosterol in it, and ergosterol gives the cell membrane rigidity and stability, much like cholesterol gives our cell membranes rigidity and stability. So you can imagine that ergosterol might be a good drug target because we don't have ergosterol in our cell membranes, we have cholesterol. And because ergosterol is important to the integrity of the cell membrane. And in fact, you see that with several drugs. We have the azoles. These are going to break down one of the steps in ergosterol synthesis. Terbinafine is going to break down another step in ergosterol synthesis. Amphotericin B and nystatin are going to interact with ergosterol in such a way as to form pores, and this is going to inhibit or destroy the cell membrane's integrity, right? So ions can flow freely, and then so can water. Then over here you have the echinocandins. These guys are actually going to interfere with the cell wall. And so they interfere with the synthesis of these building blocks of part of the cell wall. Then over here you can see griseofulvin. It's going to interfere with microtubules. And flucytosine, again, interferes with DNA and RNA synthesis. Don't worry so much about these guys. I want you to focus on the azoles and amphotericin B, and I want you to know that they're going to affect the fungal cell membrane. Okay, antimalarials. Antimalarials are going to be antiprotozoan drugs because the parasite that causes malaria is a protozoan. The ones I want you to be familiar with are chloroquine and primaquine. And what these guys do is they basically interfere with the parasite's ability to break down heme. And so toxic byproducts build up inside of these parasites and it kills them. I want you to know metronidazole. The brand name of this you might have heard of is Flagyl. This is another antiprotozoan drug, and I'll talk a little bit more about it when we do our antibiotic review. Sulfonamides and tetracyclines can also be active against some protozoa. Antihelminthic drugs. These guys are going to immobilize or disintegrate the parasite or inhibit its metabolism. I want you to be able to recognize these guys, okay? So recognize mebendazole and albendazole. These guys are broad spectrum. They're going to inhibit the function of the worm's microtubules, which is going to inhibit cell division. But they also interfere with glucose uptake, so the worm actually ends up starving. I also want you to be able to recognize pyrantel and praziquantel. These guys paralyze the muscles of the worms. Okay, so antivirals. The problem with antiviral chemotherapeutic agents is that selective toxicity is essentially impossible. And this is because the virus uses our cells to replicate itself. And so really the way to get to the virus is to target our own cells. Most antivirals are going to be designed to block some part of the virus multiplication cycle. For example, some will block penetration into the host cell. Some are going to block viral replication. Some are going to prevent maturation of the viral particles, so mature infective viruses cannot be released from the cell. Some still are going to prevent release itself. All right, so let's just go through a few examples of antivirals and their mechanisms of action and what part of the virus life cycle is being affected. So for example, amantadine. This guy prevents viral uncoating. The problem here is that currently viruses have developed almost complete resistance to it. So amantadine is not really used anymore as flu treatment. Now what you have probably heard of is Tamiflu. Tamiflu is going to block neuraminidase, which is an enzyme involved in viral release. So the virus cannot be released from the infected cells. It cannot go on to infect more cells. All right, many of the anti-herpes drugs are going to mimic the structure of nucleotides. Remember, nucleotides are those nucleic acid building blocks. So they're going to compete for a place on the growing DNA molecule. So for example, acyclovir is one of these drugs. And when you interfere with the DNA molecule replicating, you're interfering with viral replication step. Okay, this is a table of anti-HIV drugs, and you can tell several of them on the market. And so what I might do on a test is I might tell you that a patient with HIV is taking a binding inhibitor. And I will tell you that binding inhibitors prevent binding of the virus to receptors on the host cell. Then I'm going to ask you which step of the viral multiplication cycle, or which steps are being targeted. And in the instance of binding inhibitors, we're targeting adsorption and entry. So another example would be the nucleoside reverse transcriptase inhibitors. These guys are analogs, so they're lookalikes, right? And they're going to be incorporated into the viral DNA molecule. And that's going to stop that viral DNA molecule from being able to grow. And so which step is this going to interfere with, I may ask you. And you need to figure out that if the virus can't make its DNA, then it's targeting the viral replication step of the multiplication cycle. Okay, so be very familiar with the life cycle of a virus, all the steps in it, and then go through here and make sure you understand why a certain drug prevents a certain step, okay? You don't need to memorize them, just think big picture stuff. Just if you understand the steps of the virus life cycle, these drugs should make sense to you. Okay, so here's an example of a question you may be asked on the test. And one thing I want you to get used to is seeing questions like this with extensive question stems. So lots of words here. And what you need to know is that most of this is unnecessary. So when you see a big question like this, don't freak out. Just realize you need to hunt for the most pertinent information. So let's go ahead and read it. A 32-year-old woman presents to her primary care physician with symptoms of fever, chills, muscle aches, and a sore throat that have developed over the past 2 days. Her physician diagnoses her with influenza. To reduce the severity and duration of her illness, the doctor prescribes oseltamivir, a neuraminidase inhibitor. Neuraminidase allows for the viral particles to be released from the host cell. Okay, notice here, we have not even been asked a question yet. So that was all background information. Here comes the actual question. Which step of the influenza viral life cycle is oseltamivir specifically inhibiting? Okay, so what you need to do is you need to go on a hunt, and you're looking for the most pertinent information. This is talking about the viral life cycle, so we need to think, what's the mechanism of action here? Well, it's a neuraminidase inhibitor, and that's going to prevent viral particles from being released, right? If neuraminidase normally allows for viral particles to be released, we're preventing it, so we're going to be preventing the release of new viral particles from the host cell, or C. Okay, so now let's talk a little bit about drug resistance. Drug resistance is an adaptive response in which microbes are going to begin to tolerate an amount of the drug that normally would have been inhibitory towards them, okay? And this is going to be the result primarily of genetic versatility, or the adaptability of microbial populations. And resistance is the big enemy of antimicrobial therapy. So how does drug resistance develop? And I'm going to primarily be talking about drug resistance in bacteria, but similar mechanisms exist for fungi, viruses, and protozoa as well. So you've got two main ways. You can have spontaneous mutations. This is going to occur when the microorganism is replicating its DNA. If there's an error in reading that DNA, the error can get passed on to the daughter cells. Or you can have acquisition of new genes, and these are going to come outside of the microorganism from another microorganism. Another term for this, this general process, is horizontal gene transfer. Now, bacteria are not the only organisms that undergo horizontal gene transfer. Many organisms do, including fungi, protozoa, viruses as well. Again, the exact mechanisms are going to be a little bit different based on which microorganism we're talking about, but the big picture stuff is kind of the same. So they can either develop spontaneous mutations, these are new mutations that occur from errors in reading DNA, or they can get new genes from outside of themselves, from other organisms. These are the methods through which that can occur. So let's say you have a bacterium and it's just moving around in its environment, and it comes across a piece of free-floating DNA. Sometimes when other microorganisms die, they leave behind, pieces of DNA, of their DNA. Another bacterium can come along and scoop up this free-floating DNA and take it in and incorporate it into their chromosome. Another way that genetic material can be transferred horizontally is through transduction. What happens here is it involves a bacteriophage. So remember, bacteriophages are viruses that specifically infect bacteria. And what happens is you might get a bacteriophage that infects a bacterium. That bacteriophage is going to make it's going to lead to the assembly of a bunch of new viral particles, right? Well, some of those new viruses may latch onto or catch pieces of the bacterium's DNA. And when they leave, they go to infect another bacterial cell. Some of this DNA is deposited into the new bacterium, and that bacterium can incorporate the DNA into its chromosome. Okay, another method, one that we have just touched on, is conjugation. And remember, this is where two bacteria are going to come together and physically contact one another via a long rigid tube called a sex pilus. And they can transfer genetic material between one another via that sex pilus. Most commonly, they're going to transfer these things called resistance factors, and these are just plasmids. Remember, that's going to be the extra genetic material, the small circular genome that many bacteria have. It's just going to be plasmids that have drug resistance. Those are called resistance factors. Another thing that you can have are these things called transposons. These are also known as jumping genes. And what happens is they have a tendency to kind of jump from one area of a chromosome to another, maybe to a plasmid, from one plasmid to another, etc. And these transposons can be transferred between bacteria as well. And some of them also confer resistance. Okay, so this is just kind of showing the three major mechanisms of horizontal gene transfer that you see in bacteria. So here is a dead bacterial cell, and this is its DNA just kind of strewn about. And you can see this bacterium is picking up one of those fragments of DNA and incorporating it into its own genome. Or alternatively, it can incorporate it into a plasmid. This over here is a bacterium that's infected with a bacteriophage. The bacteriophage picks up a bit of the bacteria's DNA and takes it and inserts it or introduces it to the new bacterium, which can then take that segment of DNA and incorporate it into its own chromosomes. Finally, you have conjugation. And notice how these bacteria are making physical contact with one another. And there would be a tube here communicating between both bacterial cells. And through that tube, one bacterium is going to transfer its plasmid to the other bacterium. And remember, these plasmids carry resistance genes, genes that encode for the ability to resist certain drugs. Okay, so how exactly does the bacterium defeat the drug? What are the mechanisms or the strategies that a bacterium uses to fight against our antibiotics? And how exactly do genes like resistance factors code for these resistance abilities? The first strategy bacteria use is drug inactivation. So, for example, inactivating the drug penicillin. Now, go back and recall how penicillin works. Remember that the cell wall is going to be made out of these long sugar chains that are cross-linked with little protein fragments. And there are these enzymes that do that cross-linking. And what they're doing is they're building a really strong lattice, that peptidoglycan, and multiple layers are going to be used to compose the cell wall. What penicillin does is it goes in and it interferes with those enzymes that do the cross-linking. So the lattice work is not very strong, and that weakens the cell wall, resulting in rupture and death of the cell. Now, what some microorganisms do is they develop an enzyme that breaks down penicillin, and it's called penicillinase. And what this enzyme does is, you see this ring structure right here? This is the beta-lactam ring. This is the part of the penicillin molecule that interacts with those enzymes and blocks the ability of the natural substrate to interact with those enzymes. Well, if you break this beta-lactam ring, penicillin becomes inactive. It can no longer interfere with those enzymes, so those enzymes can go ahead and cross-link that peptidoglycan and build a nice strong cell wall. So this is strategy number one. Develop something that will inactivate the drug directly. Okay, another tactic is to decrease permeability of the drug. So if the cell is not taking in the drug, it's not going to be affected by the drug. Here on the left, we have a normal cell surface of the microbe. And we've got receptors that normally interact with the drug, the drug, and bring the drug into the cell. Well, let's say a mutation occurs in the gene that codes for this normal receptor, and now it's an abnormally shaped receptor. And that abnormally shaped receptor doesn't interact with the drug at all, so the microbe doesn't bring the drug in to itself and poison itself, essentially. So this is strategy number two. Just stop bringing in the drug. Alternatively, you can pump the drug out faster than the bacterium can metabolize it. So what happens is the bacterium might activate drug pumps. And what these drug pumps do is they take the drug that's coming in and they just spit it right back out. So no drug really stays around inside of the microbe long enough to be active. Here, number 4, the microbe can change the shape of the drug binding site somehow. So here we have a drug that's binding to the large subunit of the ribosome. And let's say that this binding site gets changed just ever so slightly. And now the result is these drug molecules can't bind to the ribosome and block the ribosome's action anymore. So the drug ends up not having any effect. Okay, and finally, the microbe can use an alternative metabolic pathway. So let's say this is the normal metabolic pathway, A to B, and remember there's going to be an enzyme here, and then B gets made to C, another enzyme here. C gets converted to D, enzyme in the middle, and D, through another enzyme, gets made into the final product. Let's say we have a drug that's going to block the conversion of B to C, so it blocks this enzyme here somehow. What the microbe can do is it can turn on an alternate pathway. So it can take B and instead of converting it to C, it's going to convert it to C1 via this enzyme. And then C1 can go on to become D1 via this enzyme. And then another enzyme is going to convert D1 into the final product. And in this way, the microbe can outsmart our drug. Okay, which of the following effects do antiviral drugs not have? Okay, so this is asking for not have. Well, we know antivirals stop parts of the viral multiplication cycle. So look here and see which ones of these would be involved in the viral multiplication cycle. So B, stopping virus synthesis or DNA replication. That's one of the steps of the virus multiplication cycle. C, maturation would be a step of the virus multiplication cycle. So drugs are developed to inhibit virus maturation. D, blocking virus receptors. We do have drugs that do that as well, and that would block viral adsorption and entry. So really the answer here is A, killing extracellular viruses. And this should be obvious to you anyway, because viruses don't exert their effects extracellularly. They are obligate intracellular parasites. That means they only do their damage inside of a cell. All right, so we've talked about the strategies that these bacteria will use to avoid the effects of our drugs. We've talked about the mechanisms through which they gain these strategies. For example, spontaneous mutations that occur during binary fission, or horizontal gene transfer, either through transformation, transduction, or conjugation. But how do populations of bacteria, whole populations, become drug resistant? Well, it all kind of just starts with dumb luck. What happens is large populations of microbes are statistically going to have some cells in them that have these drug-resistant characteristics already, either due to prior mutations that they experienced or horizontal gene transfer or both. They don't have an advantage, a selective advantage, until the entire population of microbes is exposed to the drug. When the microbes become exposed, the antibiotic sensitive ones are going to die, while the resistant cells are going to survive, and they're going to pass on their genes. They're going to proliferate. And every generation that occurs during drug treatment, right, as long as the drug is around, the environment is going to be selecting for those drug resistant cells. Eventually, you're going to kill off all of the sensitive cells, and all that's going to be left are the resistant guys. And that's going to be essentially the entire population. This is just one of many examples of evolution due to natural selection. Okay, and this just illustrates that natural selection process. So here we have our bacterial population, and you can see the majority of them are going to be sensitive to the drug. That's what the green color means. But a few already have drug resistance, either through spontaneous mutation or they got it from another microorganism through horizontal gene transfer. Okay, so this is illustrating natural selection. And here we have our bacterial population. You can see green means that they are sensitive to the drug. Purple means that they are resistant to the drug. So a minority of our population is already resistant to the drug this patient's about to take. Now, let's say the patient takes the drug. And so what we've done is we've applied selective pressure to the environment. And so the sensitive organisms are going to die while the resistant organisms are going to live and reproduce. And when they do, several generations later, you're going to see that the majority of the bacterial population that remains has drug resistance. So how do we limit drug resistance? Well, it's going to be all about how we use these drugs. For example, providers have the responsibility to make an accurate diagnosis and then correctly choose a corresponding drug for that diagnosis. Patients have a responsibility to take the drug as prescribed, especially for the prescribed amount of time. And then another strategy that can be used is combined therapy. This is using 2 or more antibiotics together. And what this is going to do is it's going to increase the chance that if the microorganism is resistant to one of the drugs, it won't be resistant to the other drug. And so in this way, you can get rid of the resistant members in the population. So let's say that this patient here with this microbial population, this infection, is prescribed a penicillin. And let's say these purple guys are resistant to penicillin. Well, if the patient takes just the penicillin, this is the natural progression of what's going to happen. We're going to get a population of penicillin-resistant bacteria. Let's say, however, that in addition to prescribing a penicillin, the provider has also prescribed an aminoglycoside. And let's say that these purple guys, while they are sensitive to penicillin, they're not sensitive to aminoglycoside. So what's going to happen is when you take both of those medications at the same time, it's going to kill all of the bacteria, the penicillin sensitive ones and the penicillin resistant ones as well. So you're not going to have this outcome here. You're not going to select for the most resistant microorganisms. Okay, so in addition to how we prescribe the medication, how we take the medication, how we use it, another strategy to limit drug resistance is research into these drugs, into new drug development. And so research in general is going to focus on developing better medication that's more effective, has fewer side effects, isn't inactivated easily by the microbe, things like that. However, there's some challenges to drug development. First of all, drug resistance tends to occur rapidly due to the evolving bacterial populations like we just talked about. So over time, drugs are going to lose their effectiveness, and this translates into drugs losing their marketability. So if you are a pharmaceutical company and your job is to sell medication, you want to be able to sell that medication from now until the end of time. Unfortunately, antibiotics don't carry that promise with them. They carry with them a limited window of time in which they will be effective. And we don't know how long that window is for each antibiotic, but it is guaranteed to be a limited window because these microorganisms evolve and adapt so rapidly. In addition to that, antibiotics are not very profitable. It costs a lot of money to develop a new drug, and antibiotics are pretty cheap as far as medications go. So the drug companies aren't making as much profit off of antibiotics. So these are kind of two big reasons that companies are not incentivized to develop new antibiotics and why we're lacking in new antibiotics compared to other new drugs on the market. Okay, long-term strategies. So in general, we need to educate providers about proper prescription of antibiotics. We need to educate patients about taking antibiotics for the duration prescribed. So education is a big long-term strategy. Some hospitals have put in place antibiotic stewardship programs, and what these programs do is it basically puts a team of people overseeing which antibiotics are being used, and they may restrict the use of some antibiotics to only a couple of infections. And they may have restrictions that say, unless approved by antibiotic stewardship team, you may not prescribe daptomycin or something like that, okay? Another thing that we've got to do is we have got to stop adding antibiotics to animals, to their feeds. This has got to be stopped worldwide. Okay, another long-term strategy is to increase programs that make effective therapies available to low-income people. And one place that we see this is in HIV patients. So let's take a step back and let's talk about how viruses replicate themselves. So they're going to get into a cell and then they're going to replicate their DNA or their RNA, and that DNA and RNA is going to go on to form new virions, okay? Those virions or virus particles are then going to be released from the cell and go on to infect new cells. Now, when the virus is replicating that DNA or that RNA, there's always a chance that errors are going to occur. And so mistakes get introduced and mutations happen. This is one of the reasons why viruses mutate so rapidly, is because they're replicating so rapidly. They go from one cell to another cell to another cell. And each time they're replicating their nucleic acids. And each time they do that, it's an opportunity for mistakes to be made and mutations to occur. One of the things that anti-HIV medications do is they decrease the viral load. That is, they decrease how much virus is in a patient's system. And that decreases the likelihood that they're going to spread it to someone else. The less virus particles there are to infect you, the less likely you're going to be infected. The idea here is that if we made HIV medication free or affordable to everybody, regardless of their ability to pay, we're going to bring down the viral loads of everyone all at the same time. And so there's not going to be as much spread of the virus. And that's going to limit these opportunities that the virus has to replicate, right? So when you limit the opportunities the virus has to replicate, you're limiting its ability to mutate over time. So that's why this is a long-term strategy to reduce drug resistance. Okay, and then vaccines are going to be an effective long-term strategy to reduce drug resistance. If you can prevent the infection altogether, you never need antimicrobial drugs in the first place. And so the microorganism never has an opportunity to develop a resistance to these drugs. All right, side effects. So about 5% of all people who take an antimicrobial are going to experience a serious adverse reaction to that antimicrobial. Major side effects that we worry about, we're going to worry about direct damage to body tissues due to the toxicity of some of these drugs. Some of these drugs are very toxic to particular tissues, especially the organs of hearing, the kidneys, and the liver. We also worry about allergic reactions, and the biggest fear with allergy is the development of anaphylaxis or anaphylactic shock. Okay, and that's a life-threatening condition where the body essentially overreacts to an allergen. Finally, another major side effect that can occur is dysbiosis or disruption of the body's microbiome. And when you disrupt the body's normal non-pathogenic bacteria, you can get what's called superinfections. Okay, so here is an example of a superinfection. One thing to know is that in the normal microbiome, most of these are going to be non-pathogens. However, it is totally normal for people to have a few pathogens that colonize them. They are kept in check by the non-pathogenic bacteria. However, when you take an antibiotic, this antibiotic doesn't just kill the pathogens. It's also going to kill good bacteria who are just living their lives. And when you do that, you worry about leaving behind drug-resistant pathogens that can then overgrow and cause a superinfection. Okay, so this is just a table showing the different antimicrobial drugs and the different bad things that can happen if you take them. Don't worry about memorizing this. I just wanted to point out that some really serious things can occur from taking these medications. For example, cephalosporins can cause bleeding problems, can cause inflammation of the kidneys. Chloramphenicol can cause a type of anemia. Aminoglycosides are toxic to the ears and to the kidneys. Azithromycin, you get this in a Z-Pack, can cause heart arrhythmias, okay? So these medications are not benign. And those of you who go on to become prescribers, you need to remember this when you're choosing the best medication for your patient or choosing to treat your patient with antimicrobials at all. Okay, so selecting an antimicrobial drug. We already pretty much talked about this, but I just wanted to go into depth on a couple more of the factors. So remember that the most important of those factors is going to be the nature of the microorganism that causes the infection, whether or not the microorganism is susceptible to a given antibiotic, and of course the overall medical condition of the patient. Is the patient stable? Are they critically ill? Do they have other health problems? Do they take other medications? Things like that. Best practice is to take specimens before you start the patient on antimicrobial therapy. So if you suspect the patient has sepsis or a blood infection, ideally you would take a specimen of blood before you begin antibiotics. And so then you can culture that specimen of blood, grow the microorganisms, and examine them through various methods and determine which drugs they are most susceptible to. Now, how do we determine whether or not a microorganism is sensitive to a given drug? Well, we use, there's several ways that you can do it, but the two ways we're going to talk about are going to be the Kirby-Bauer disc diffusion test, and this is what we'll be doing in lab this week, and also the tube dilution test we're going to talk about. And the tube dilution test is useful because it's used to determine the minimum inhibitory concentration or the least amount of drug that you need to use in order to inhibit microbial growth. Okay, so here's the Kirby-Bauer disc diffusion test. This diagram is showing a very large petri dish, so that's what this big circle is, and they've grown bacteria on this big circle, this big petri dish. And so this green area is the area of bacterial growth. What they did next was they took these discs that have been soaked in different antibiotics. For example, this one has been soaked in ceftriaxone. And they laid these discs directly onto the petri dish, onto the bacteria. And then they incubate it. And what happens is bacteria are going to grow, but they're going to be inhibited around these different antibiotics. And the degree, you can measure the degree of inhibition. This is called the zone of inhibition. It's the clear area around each antibiotic. So for example, you can tell the zone of inhibition here on this antibiotic, this big white area, is larger than the zone of inhibition for this antibiotic, much smaller area that's not growing bacteria. So you can deduce that the bacteria are going to be more resistant to this antibiotic or more susceptible to this antibiotic right here. That's how the Kirby-Bauer disc diffusion test works. All right, here's an actual picture of it. it. So they've taken their plate, their agar plate, and they've grown Pseudomonas on it here. And Pseudomonas tends to grow green. Then they've taken these little antibiotic discs and they've placed them directly on top of that bacteria. They incubate it. And then they come back after a certain period of time and they measure the zones of inhibition around these different antibiotics. You can tell just by looking at it that this antibiotic was pretty effective. There's a large zone of inhibition where the bacteria could not grow. This antibiotic was essentially useless. You've got bacteria growing all the way up onto that antibiotic-soaked disc. So you know those antibiotics are not effective at all. This is just showing you the same thing, just with a different pathogen. Okay, this is showing measurement of the zone of inhibition, and you're going to do this in lab yourself. So when you do, you need to measure the diameter of the zone of inhibition. Okay, the tube dilution test. So what they do is they take a known concentration of bacteria. So this is a broth that has bacteria in it, and they put it in a bunch of different test tubes. So all of these test tubes have the same concentration of bacteria in them. Then they have a control tube, so this one is not going to have any medication added to it. Then they start adding medicine in small increments. So you've got 0.1 micrograms here. And then they look at the tube and they look to see whether or not the turbidity or the cloudiness disappears. If it doesn't, they add more medicine. So they are essentially doubling the dose of medicine every time they add on to a new tube. Now, at some point, they're going to get to where they have enough medication that it kills off those bacteria and it clears out the tube. The turbidity disappears. And at that point where you can visually see the bacteria are no longer, that is called the minimum inhibitory concentration. So the example here, the minimum inhibitory concentration would be 1.6 micrograms. Okay, so those were examples of in vitro activity of a drug. In vitro, remember, means in glass. So that's an example of how microbes react to these drugs in the laboratory setting. Now, that does not always correlate with how these drugs work in the actual body. So if therapy fails, a different drug, a combination of drugs, or even different route of administration should be considered. Now, when you're choosing an antibiotic, or really any drug, you want to choose a drug that has the highest level of selectivity, but the lowest level of toxicity. And that level of toxicity is measured by the therapeutic index. And what the therapeutic index tells us is it's a ratio of the dose of the drug that's toxic to people compared to the dose of the drug required to get some sort of effect. You can express the therapeutic index this way, mathematically. So this is the toxic dose, the dose that causes toxicity in 50% of people, divided by the dose that is effective in 50% of people. Now, high index is going to be desirable, and let's talk about why. You want this number to be big. That means you want the number on top, the numerator, to be bigger than the number on the bottom, or the denominator. And this makes sense because ideally, you would have a drug where the toxic dose is so high, you had to eat a ton of this medication in order to get any toxic side effects. That's how big a number you want here. Also, you want a really small effective dose. You want to be able to take the least amount of medication possible in order to have an effect. So remember, therapeutic index, high numbers are desirable. Okay, and that makes sense when you think about it mathematically. Okay, final question. In a tube dilution test, the MIC is the blank of a drug that is required to inhibit growth of a microbe. Is it A, the largest concentration, B, the standard dose, C, the smallest concentration, or D, the highest threshold? Well, if you go back, we're looking for the MIC, and we said the MIC is the minimum inhibitory concentration. That is the smallest concentration of drug that visibly inhibits microbial growth. So the answer is C, the smallest concentration.